till this pandemic is over and until people are well aware of the risk and what they can do, we will continue talking about this and having discussions. Today we're going to have Mr. Michael Tylor, and Janet, who will be joining us soon. They both are respiratory therapists. They are, in my opinion, the main front line. All the RTs, which respiratory therapists, are the main front line that they're fighting, not just this pandemic, not the coronavirus alone, but any kind of disease or any kind of epidemic that we face. They're the first people that are affected by it, starting with the shortages, starting with the stress with the job, etc. So I will have Mike to it, and introduce yourself, Mike, to everyone, and let's get directly to what we're here for.
Okay, hello. My name is Michael Tylor. I've been a respiratory therapist for about 11 years, and prior to that, I was started out as an exercise physiologist. So really spending a lot of time dealing with cardiopulmonary science and care. And as you know, respiratory therapists are not just clinicians, we're also technicians. So we have to be able to have the skills and knowledge and capability to be able to manipulate machines, clinical programs that are part of machines that allow us to deliver pressures, allow us to manipulate airways. So we do need to really have a knowledge of the technology that's out there when it comes to the machinery that we use to care for people, as well as knowing the disease process that somebody who's dealing with any cardiac or pulmonary issues, to understand a disease process so that we can better treat those people.
Can you explain those in like simple terms? Not everyone is a clinician out there. A lot of people are just normal, your everyday normal people who are dealing with this pandemic, and they're scared and they don't know what is your role, what is respiratory therapist, in just simple terms. If you can explain that, so people can understand.
So when somebody is when your lungs are diseased, so since we focus primarily on breathing, okay, so we know that when we breathe, we're bringing in a certain amount of oxygen into the lungs, and the lungs have to be able to process, pull the oxygen out, deliver that oxygen via the blood. So the heart and the lungs have to work together to be able to keep us sustained, functioning normally, and also keep all of our major organs working. So if your heart and lungs can't work properly, it has an impact on the rest of your body, your brain, your kidneys, your liver, even your skin, anything that depends on oxygen and blood. It all starts in the lungs. So we do play a major role in keeping people stable that may have many complications, many health problems. With a respiratory disease, not just we're talking about COVID-19, but you have other things like COPD, influenza. You have many different other viruses and bacteria that can cause the lungs to not function properly. Different people will have pulmonary diseases, lung diseases, problems, not just due to, say, smoking, which most people are familiar with, the fact that when smokers, after so many years, damage their lungs to the point where they may need oxygen, they may be more susceptible to getting lung diseases. And something like COVID is definitely going to have a greater impact on somebody who has a history of smoking or already has lung disease. we have to keep that in mind. The people that we see in the ICU today that are on ventilators probably got sick about 14 days ago. They probably started seeing symptoms about 5 days ago.
Mm-hmm.
And now they're probably intubated if they're in the ICU on a ventilator or breathing machine. And these people typically are that we're seeing that these people are the ones that don't have a great cardiopulmonary health history, meaning their heart and their lungs aren't in the best of shape already before getting the disease, if
Mm-hmm.
that makes any sense. The respiratory therapist um, in the acute care setting, which you may hear the term ICU, intensive care, is going to run the breathing machines, the ventilators. Um, I would say 90% of the time, 99% of the time, your ventilators are going to be operated by a respiratory therapist. So that machine um, is used to put pressure into the lungs. It not only gives our lungs volume of pressurized air, but it also gives us oxygen. When the person can't breathe on their own, the machine has to breathe for them.
Mm-hmm.
Okay. So with a disease like COVID-19, oh, there you go. So you have a picture of the background of a typical ventilator machine, which has a screen, which allows the therapists, the doctors, and the nurses to see all the different settings, which include pressures, oxygen percentages, and volumes, rates, how many times somebody breathes in a minute. The respiratory therapist, the pulmonologist, the nurse practitioners that are more pulmonary focused, the physician assistants that are more pulmonary focused, we all kind of work together to try to figure out what kind of settings each individual will need based on the severity of their condition. So you may have 10 people on a ventilator, but that are sick, and all 10 people could have 10 different types of settings. Okay, so we have to customize the setting to the individual, and something like COVID-19, um, it can cause different symptoms in different people, but the main thing is um, that it eventually ends up people end up in respiratory failure. So the respiratory therapist has to be able to, along with the doctor, the pulmonologist, along with the practitioners, they have to be able to figure out how to keep these people stable using this machinery. In the ICU, we have them usually on some sort of sophisticated setting, or they're on a high flow of oxygen. And if we can get them off the ventilator, meaning what we call wean them off, that's a successful moment. We usually put a tube into their lungs, hook that tube up to a circuit on the ventilator that pushes the pressurized air and oxygen gas mix into their lungs. We give them a certain amount of volume with a certain breathing rate, a certain percentage of oxygen. So that's the simplest way that I can kind of explain how a ventilator works.
So that's basically
And we're trying to keep that person alive.
how the
Um,
ventilator work, and that
Once we can get them to a point where we can get them off the ventilator, they may still need oxygen. They may still need respiratory care. They
Mhm.
just might not need to be in the ICU. So they may be pulled out from an ICU. They may be put in what's called a long-term acute care environment, or they may be put in a skilled nursing facility, which kind of leads me into the next point
Mhm.
about what it is, like to be a respiratory therapist during this time. The respiratory therapist, or many of us are working in different environments. Personally, I've been spending most of my time in a skilled nursing facility,
Uh-huh.
which includes long-term care. residents who live at the facility. And these facilities also include a rehabilitation hospital component.
Mm-hmm.
So you have people that are coming there for short-term stays as well. Most of the time, these folks are coming from a hospital. So the respiratory therapists at the hospital, if you want to talk about front line, these are the folks that are in the ICU. These are the people that are seeing.
I think we lost Mike.
Can you see me still?
Yeah, we just lost you for a minute, but you're back.
So once people leave the hospital and they're taken off the ventilator, or maybe their oxygen, the amount of oxygen they get has been decreased, then they come to us. They come to an LTAC, which is the type of facility I'm working in now, which is a long-term acute care hospital. It's still acute, but it's not the ICU. They're not getting the same kind of care there.
Mhm.
Um, as if they just went into respiratory failure and they're trying to save their life. They've stabilized them. Those respiratory therapists will kind of give us the information that we need. They'll come to the long-term acute facility for further rehabilitation. And then from there, if they're able to get better, then they might go to a nursing facility. Right now, we don't really know what the process is going to be here in our South Central Pennsylvania region.
Uh-huh.
It hasn't been as hot as, say, New York, Florida, Louisiana. Um, we're just now starting to get cases, more cases in the York, Harrisburg, Lancaster area. So it's still kind of left up in the air what's going to happen once these people start to get well. Are they going to continue to be quarantined, or are they going to start sending them other places?
So in another word, if I don't want to cut you off here,
Mhm.
but as a respiratory therapist who's working in the front line, and like I said earlier, I think you guys are the main front line. I'm not putting us down as nurses or doctors or anyone who's in the healthcare. Uh, Respiratory therapists and certified nurse aid are mainly they work directly in more dangerous situation, and they're not recognized as the other healthcare workers. I'm not here to blame, but I'm trying to explain that your job is more in the front line. You're dealing directly with the droplet. You're dealing directly with the issue with few ventilator, with the issues that you are going to face,
Mhm.
seeing it front like first. What you say about the shortages, and not just in respiratory therapists and in
Mhm.
ventilator? What is this going to affect us here in Pennsylvania? And what do you think about opening back? And I'm not trying to get political here with you, but you've seen what is happening in the hospital now. A lot of people don't see it as serious as you and I see it, or maybe Don. Hi, Don. I miss you too. Don is the administrator of many great facilities that we work with, and she is amazing. If you can join us, Don, I have the link up there. We would love to have you. Even just to say your opinion, what you think, um, about this specific situation. But what do you think, Mike, when it comes to ventilator RTs and healthcare worker?
Well, and just kind of going back to what you were saying directly, if anybody's going to make somebody cough, it's going to be an RT. So
Mhm.
yeah, you're right. We're anything that we do in front of the patient may cause them to cough, and we're going to be coughed on. We're going to be sneezed on. We're dealing with secretions, not to gross
Mhm.
anybody out. Anything that we do,
Be grossed out.
intubation, extubation, yeah, I would agree that there's probably a higher percent chance that, um, you know, we would be at a higher risk, I should say, of contracting something. With the types of procedures that we do, the amount of time we spend in an aerosolized room, where, meaning like if
Yeah,
somebody's breathing aerosols that's in the air, yeah, obviously it's a definitely a higher risk. As
yeah.
far as like shortages, you know, I think the only this is going to sound kind of weird. The only good thing, if I want to say it's a silver lining in this whole dark cloud of a pandemic, is that it
Mhm.
brings more light to the respiratory therapy profession. I think there's a lot of people out there who probably now who didn't know what a respiratory therapist was before. Now they kind
Yeah,
of know. This has shed a spotlight on the respiratory therapy profession, and there have been people out there for years lobbying for respiratory therapists to be to get an MPI number for us to be a billable service. So this kind of does promote the profession, and I'm glad that there are people out there that are bringing us to the forefront as being practitioners. Um, so there is a shortage of respiratory therapists. I can't remember the number as far as how many of us there are nationally, but just to give you an idea of what the situation is, if you know a respiratory therapist, I guarantee
mhm.
that they have been offered a lot of money to travel to places where they're needed. I've probably gotten about, I would say about 20 offers to go to different states. Washington State was the first one I got offered to go to, followed by New York. I mean, they're offering like 85 to $100 an hour for RTs to do 13-week contracts. There's just not enough respiratory therapists to operate the ventilators. And on top of that, like you said, there's not enough ventilators. Um, I know that they've been putting things in
Why is
place.
this important? I am not trying to cut you off, but I'm
Yeah,
trying to make people understand why this is important, why it is very serious not to have enough ventilators, enough respiratory therapists at this time. If we say, for example, we open up and people don't take this serious and we get massive amount of cases, god forbid, just like New York or in Italy. Before we went on, you were talking about Italy. What
yeah.
does this mean to us? What did this mean to the normal person listening now?
Well, I think the issue is I think we're taking it serious now, but it's a little late. I think yeah, there we had time to make sure that we had enough ventilators, maybe and things like that. Yeah, it's bad because obviously, um, we need these machines to keep people alive. We were not prepared nationally. We
Yeah.
just weren't prepared nationally. In my opinion, I know there's people out there that say that, oh well, Italy wasn't prepared. I think Italy was better prepared than the United States, personally. I
Hmm.
think that because of their system, they have a public health system
Hmm.
um, compared to what we have, which is a for-profit system. Um, I just think that when you don't have a pandemic, there may be some things that you can critique about a system like that. Things people might not get appointments right away, but when the what hits the fan, now that system can kind of show where it's strong, whereas it has process in place to handle something as heavy as COVID-19 the way that they can handle. I don't think our system is built for that. So now you can see, to your point, um, as things are starting to heat up, we don't have the numbers as far as the ventilators. What's that going to do?
Hmm.
It's important because um, you're going to have to make a decision on who lives or dies. You're going to have to make a decision on who gets that ventilator when we have too many people that are in need and there's not enough ventilators. Somebody's going to have to pick and choose. And how
Which
how
was
how are
the
they going to
issue
do
in
that?
Italy. And I think it's a lot of people view it as an unethical or think about it as how can you do that. But this is to explain this to everyone out there. This is a way of like when you go to the hospital and you see the nurse area, like you get first, you meet one nurse outside. That nurse listen to you and listen to X and Z, and then decide who goes first. A lot of us might be upset, you know, when you sit in the nursing home. Hi, Janet. Janet just joined us. Uh, Hello, my
Hello.
darling. I'm gonna put you up. So when we all go in the hospital room, like the emergency room, and you get prioritized, or you put in the last, you know, you put last, and someone just walked in, goes in front of you. That's not because you're not important. That's because this person have more issues. They need to be seen first. This is the same what Mike is just saying. When you are put on the spot, you're going to choose who need to use the ventilator. And sometimes you are going to face that. And I don't know if I can call it an ethical. I don't know. I don't know what we call it. But before we continue the conversation, hello, Janet.
Hi. I can't.
Introduce yourself to everyone. I'm glad you were able to join us.
Sorry, I'm late. I can't see you. Is that proper?
Oh no, you can. All right, hold on. Let me try to fix this so you can see me. Do you see Mike?
No, I see nobody, but I see a question from a person.
And you can you see us now?
Oh, wait a minute. Yeah, but this question is in my way here.
Okay, I will fix that right now. And I think you turn your camera
Around. Whoops, I'm seeing my.
It's okay. It's okay.
There I am.
There
Okay, but
you
I still can't get this question out of
How
here.
about now?
Nope. Still there.
You still see the question?
Yeah.
How about we can answer? Heather McDonald is our state representative. She's a candidate for District 87 as state representative, and she is a very active person who is trying to make a difference. And her question is, what do you think needs to be done in general to make sure we are prepared in the future? And as a state representative, she's going to be a state representative because we're going to make sure of that. But for her to, what her and other people in the government can do.
Okay.
So any one of you can answer that.
Well, I think we've learned our lesson, and I think making sure that we have reserves available, whether they be on a state level or a federal level. I mean, all I know is that there's some kind of an issue right now between the federal government and some of the states about a stockpile. I haven't really had enough time to get the details about this, but a stockpile of ventilators. I just feel like there should be reserves that are accessible. When I had my vendor called me up and told me and gave me the common courtesy to say, hey, if you need ventilators, you get them now. This was, about a month ago. He said, we have 400 left and they're going to be gone in 2 weeks. If you need them, order them now. I don't think we should ever be in that situation. Should there be some sort of regional stockpile based on population, something that they can, look at from a public health perspective, look at the epidemiology to be able to plan for the future and learn from this. I think that's something that shouldn't be too hard to do.
Janet, can you hear Mike?
I can hear him. I can't see him, but.
Oh, can you see me?
No, I can see nobody but my picture and 2 blank squares at the top.
Oh, we see your beautiful face and all. So can you introduce yourself for everyone watching now and tell them who you are and what you do?
Okay, I'm Janet Gilbert, and I'm a respiratory therapist, at the University of Maryland, St. Joseph Medical Center in Towson, Maryland.
Welcome, Janet. All right. So what we were talking about at the beginning, we just wanted to know what is your intake. I see Dawn is joining us, and we will have her up soon. But from you being there, working in the front line, what you missed, we were talking about how respiratory therapists, and in my opinion, respiratory therapists and certified nurse aid are the most people who are affected by this and any other, epidemic or pandemic, if you call it. This is affecting you guys the most. From where you stand, what can you tell people about it? I know you were upset a couple of days ago, and that's what brought us to this live. What do you want to say? What do you want to share with everyone?
Well, I feel like they were a little slow to the start in getting us prepared, and because when we had the Ebola out or scare, we were more prepared then. They had us go through in-services. They provided us with adequate equipment, and now all that equipment that we were told to use for that, we can't even use now, and I don't understand that. Fortunately, my hospital had 100 Vortran ventilators, which as a supply, as a backup. Thank God we haven't used them yet, but I just feel like they were a little slow to the start.
Okay. Mike was explaining to everyone what is respiratory therapist is, like what is your job description, what you do. There's few questions out there that we still didn't answer. If you don't mind jumping in answering.
Sure.
A lot of people are not taking this serious. They're not viewing it as a huge crisis as you, Mike, and the nurses out there see it. What do you want people to know, like from where you stand, what you saw in the hospital? What effect does this have on the patients?
Well, I think it's real. I know it's real. People don't realize it unless they're actually working with the patients that we see. Everything that they're saying out there as far as the symptoms that are occurring are real. Most people are keeping it home for 2 weeks prior to even coming into the hospital, and then it's too late.
Yes.
I think they need to, as soon as they develop any kind of symptoms, get to one of these drive-through areas and get tested, because I think that'll really help the spread cut down.
Mike, you can jump in.
I hear about people talking about how it's not that serious. It's funny. Just today, my partner Stacy was telling me that her teacher told the class on a Zoom meeting that the virus isn't that serious.
That's crazy.
That's
Now,
the teacher?
The teacher. Now, these are 10-year-olds. So there may be some sort of political influence there, but I'm not going to get into that. But these are the things that are still being said. I don't know. Maybe it's one of these types of things where you wish that you could scoop people up and bring them in front of these patients.
Yes.
And see what does somebody look like when they're in respiratory failure. It's real, and I don't know why. I don't know how people can't take this seriously. And it's been out there from November, December, started in China, and you could see, the story, how it developed. There's documentaries already talking about explaining, how the situation arose in China, and what the government did, what steps they took to quarantine. And it's not been a secret about how serious this is. You can see people dropping over, and the hospitals being packed. I mean, their pictures are out there, the videos are out there. Now it's not just something you see on YouTube from across the ocean. It's actually happening here in our own cities.
And
You
still
know,
people are denying it as we speak now. Opening up back the businesses. I mean, to me, this is not a smart move to do. From what we see, we have the message up here. If you both can see it from, like I said, Dawn Trainer she's been an administrator for a long time. She's a great nurse and she's been out there seeing everything. She posted up there that Montgomery County is like really awful with the COVID now. And she wrote down, but if they open everything back up now, there will be more cases of COVID, which you both know. Janet, what this going to affect you and the ventilators? Are you seeing shortages in RTs, respiratory therapists, and ventilators?
As far as respiratory therapists, yes, because it appears that a lot of people in my department are either immunocompromised or don't want to go into the area because they're scared. And as far as the ones of us that do go into the areas, fortunately at this time we have enough ventilators. Our hospital is very well prepared, but we are getting patients from other hospitals that are part of our system, and who knows what's going to happen
when you have more cases, which
Right.
expected. And once we are opening and allowing people to use to go out and just not practice safety, we're going to have an issue. Now there is another question. First of all, Carol Singleton said, I personally appreciate you, Michael Taylor. Thank you, Carol. And
thank you.
Mike and Janet are both amazing in the personal level and the professional level. But what do you both say about the mask, the usage of mask from a respiratory point, the surgical mask for the general public? I know we keep hearing different what you call it, a sentence comes out, a statement from the CDC, from the government, from just people in general. Some are supporting the use of the masks and some are against it. What do you say? We can start with Mike.
Well, if I look at it from a community standpoint, if you want to, I think there needs to be a focus on education. To tell you the truth, I've been a respiratory therapist for 11 years, and I know more about masks now than I ever have. The
Same
difference
here as a
between,
nurse.
yeah, I've learned more. I mean, the ins and outs of the difference between a surgical mask and, what kind of, penetration it can have with the droplets, and what the N95s, the different types of N95s for industrial use versus clinical use, and NIOSH approved masks, and all these different things. So if the general public has an understanding that there's masks that we use that are necessary in healthcare, and, it might not be a good idea on a community level to go and buy up all of those N95s just for you to walk into, the gas station or the grocery store. I can understand why people want to protect themselves when something like this happens. It's scary. It's a pandemic. You probably want the best thing that you can put on your face, right? So I think the issue is education. I just think that maybe people don't know why it might be important to, maybe not focus on something that's in short supply that could be better utilized in the healthcare, within the healthcare system on a whole. In the community, if they understand that a surgical mask is still a piece of medical equipment, there may be a shortage on People are making their own masks now.
Hmm.
Um, Personally, I'm a scientist. Always have been science minded. I can't really weigh in on it too much without seeing information. I think we just haven't had enough time to actually look at the studies when this with this kind of a virus and what kind of aerosol and droplet risks there are based on whether or not somebody's using a surgical mask as opposed to a N95 as opposed to a homemade mask with Philadelphia Eagles on it. You
So,
know,
Janet, what is like? Is it beneficial? What people are doing? Is it just panicking, or you think it is helpful? And from your experience, I know you've been an RT for a long time. What is the surgical mask actually do, and how people can protect themselves out there, especially if it open now?
I feel the purpose of the public wearing a mask is because if they do cough or sneeze, it's contained within their mask,
Hmm.
and then they're not spreading it elsewhere. It's really for the benefit of other people when they're coughing and sneezing, because people are rude out there. I mean, they just don't know that they should be coughing into their shoulder or sneezing into their shoulders. But as far as on the medical side, I know my hospital, we have to wear a mask at all times currently. And then, of course, we wear the N95s, and we are very fortunate. We are wearing PAPRs when we go into a COVID patient room, and any aerosol generating procedure, we are wearing PAPRs.
What is that?
It's the mask that goes over it's a whole head helmet with a motor that you put around your waist, and it generates constant airflow so
Okay.
that the virus can't land anywhere in there.
Aren't you a lucky duck?
Yes. Yeah,
Not a lot of people here
that's
are getting this.
I know.
and the
We
pappers don't have to be. You don't have to be fit tested for the papper. You
Correct.
know, so if you notice, Hagir, I shave. I
uh-huh.
don't. I don't have for the first time in probably 8 years. I don't have a beard. That's because the regular N95 to be
Right.
fit tested, you need to have skin mask to skin contact.
A lot of
But
people don't know that. Your phone is moving a lot, Janet. We
I'm
can't see your
sorry.
picture.
I'm
Yeah, it's
just trying to
okay.
get rid
It's
of
okay.
this
A lot of people, that's one of the things that people will benefit to hear. If you have, can you just explain that? If you have um, beard, too much makeup, what was that affect? Like, what people should do?
you need to make sure you have clean skin and a shaved face if you're a man.
You
That
don't
Uh-huh.
get a
seal.
Say that again, Janet.
you don't get a good seal with a beard.
Okay.
You need a very good seal in order for it to be airtight.
Okay. Okay.
Plus they come in different sizes and different shapes.
Right.
You know,
And
they
that's another thing. A lot of people go out, like the general public.
mhm.
I don't blame them for being scared and going and buying everything. But I put a post before and I said, even us, when we went to school, when we went to clinicals and we were taught how to use the mask, this is something you have to know in order for it to work right. If you put a bigger mask, that's not going to be effective. Same way if it's, not fit properly for any reason, you didn't put it right. So, I mean, what if someone is doing it now, is wearing a regular surgical mask or the N95? What should they do, Janet, to make sure that they are protected and other people are protected too?
Well, it's really only for medical personnel that should be wearing the N95s. Unless they've been fit tested, it's not going to be properly adjusted to their face.
Thank you. Hmm.
And the fit test it involves a hood, that's put over your head with a hole in it, and somebody who's trained sprays an aerosol solution And if you have the mask on and you can taste that solution, that mask isn't going to work for you. So you need to find a mask that fits where you can pass that test, where that spray is not detectable. You cannot taste it or smell it. So if you just pick up one because you have a couple packs that you got at Home Depot and you put one on, there's no guarantee. You probably just wasted your money. If you're exposed and it's not sealed, you're going to
Yeah.
breathe in. That air is going to go under the mask. It's going to go into your airways,
And
and
it's
you could be
going to give
infected.
you an illusion of protection, right?
Right.
Correct.
Same with the surgical mask. The surgical mask, if you're in front of somebody who coughs or sneezes on you and you have a surgical mask on, there's no guarantee that you're not going to be infected because that surgical mask is leaking all the way around.
Yes.
Like you said, Janet, like the large droplets, if somebody's coughing or sneezing, the larger particles will be contained. And, it's not nice. It wouldn't be a nice thing to be coughing and sneezing on somebody and having
Right.
stuff fly out of your mouth and hit you.
And
That's the physical stuff that you can see is what that mask protects you against, not the micro spray, what they call aerosol. That can still go through that mask.
Yeah.
right. We have, it's been proven that during intubation, that because we have an intubation team, which is a anesthesiologist, a respiratory therapist, and the nurses from the cath lab have all formed a team for intubation. And it's been proven that even if nothing is covering the patient's face, that it goes on in your hair, all on your shoulders, all over your
Mhm.
face. So that's why we're wearing the PAPRs. And then if a nurse, the intubation teams that we have, thank God, everybody's wearing PAPRs. But even without one, you should have an N95 with a face shield that covers all over your face, not just a plain old plastic shield in front of your face, but it's got to go to the sides of your face.
Mhm.
Because even then, your hair is still going to get it.
Yep.
So
And
And
a
the
lot of
mucus,
people think about that.
we're all wearing surgical caps now that we, and change our clothes before we leave work, and our headpieces, everything gets changed before we leave work.
So, in another word, if you are not working at the hospital, and you don't see how this is affecting patient and affecting healthcare workers, you're not going to appreciate this. But what you can do, educate yourself. Go out there, read, go to the CDC. Don't just read the news from a place that it could be giving you misinformation or, giving you fake information. CDC has a website. WHO, the World Health Organization, has a website. The Department of Health here, Pennsylvania Department of Health, has a website. And Dr. Rachel Levine, thank you very much. She's doing a wonderful job on briefing us every day about what to do, what to expect, and the fatality, all of that. Nikki said, "Hi, Janet. Thank you for all you are doing. We love you." Thank you, Nikki. We have
Thank you.
a comment from Maria. She said, "I worry about children with special needs when it comes to choosing who gets a ventilator first. I worry that they won't get priority." What would you say, Janet?
No, it's whoever needs it gets it right now.
There is a fake article out there, and people were going crazy sharing it. That's why, please get the resource before you share something. They were saying that the government is telling families that kids with special need, Down syndromes, any kind of disability, mental or physical disability, they are not going to be a priority when it comes to ventilator.
No.
We try to explain this. Can you please explain the triad, like how do we prioritize nursing or RT or doctors? How do you do that?
We're not right now, thank God, at my hospital. Whoever
Yes.
needs it gets it.
But if we have to, like Italy, hopefully we don't get to that point. But if we do, people don't need to panic. There is a system in place, and it had nothing to do with your disability, your color, your race, I hope so, or your religion.
What I think we need to focus on, though, is the patients that have been encephalopathic for years in nursing homes that are on ventilators. We do need to look at that situation and say, hey, it's time. We need that ventilator.
As hard as this sounds, it is not unethical. It is just basically thinking, using critical thinking. That's something we were all taught in clinicals, in school. You critically think and you prioritize. I forgot the actual word for that, but if you know Mike or Janet,
Can't really think about what it is you're talking about as far as that. But I agree. I mean, when we don't have a pandemic situation and you're taking care of somebody who just basically isn't really themselves, they're not really there. There's some, loved ones that have the attachment to that patient, to that person. Maybe, they're keeping them in a full code status, meaning they're going to get full resuscitation if, they needed it. You have quite a bit of folks that are on vents long term that, you have to wonder, I mean, are they there? And it's a really tough subject. I've seen family members argue about that, but whether or not they want to keep this person on the life support on the ventilator. But in times like these, yeah, that's really interesting to think about.
We're all going to face this ethical dilemma.
Yeah.
Hopefully, we don't get to that point here in Pennsylvania or anywhere else. We're hoping that the curve will be flat. But again, I'm going to repeat what I said earlier. By allowing premature opening of businesses and allowing people to go out thinking that everything is okay, this might put us back into danger. And people are not thinking about this. Janet, do you see the question from Nikki here?
Yes, and I was actually just going to respond to her because
Okay, thank you.
I am concerned because I do work also at the LTAC where Nikki worked, and they are just using basic precautions right now because there are no positive patients, but anybody can bring this virus in, and I don't feel like they're ready.
Yes.
Surgical masks are enough, but every hospital is different. Like I said earlier, when we do any aerosol generating procedure, we are wearing an N95. And they've cut out giving nebulizers to any of our patients now if they're positive, because anything that adds more aerosol droplets to the atmosphere is hazardous to us.
Yeah, they're switching people over to what they call meter dose inhalers. The typical inhaler that you would get a puff of when you squeeze it and breathe in, instead of using the aerosol. So I've seen that as well, where they've done that on a massive level in the facility.
Yes.
Yes. Do you want to respond to Carol comments here? I think I have something to say, but I'll let one of you answer. It says critically thinking and prioritizing will produce more ventilator, not sacrificing lives.
Well, that's what we do on a daily basis.
And that's what we hope to accomplish. But if there is not enough ventilator, which we are facing now, like this is what is happening now, Carl, we have to make those decisions. I mean, it won't be maybe Janet, Mike, or myself, but it would be someone working directly with us, and they might be the end receiver to that decision. Um, I hope we are not going to get to that anytime soon or never. But if we get to that point, people need to understand the choices are not based on your disability. It's based on your needs. If someone can survive without the ventilator 3 days and someone cannot survive a day, then your first choice will be that person who need it now, not the one who will need it in 3 days, right? Janet and Mike, am I correct?
Correct. And this is America. This is not Italy or Spain or anywhere else. This is America, and we do not do things like that.
Yeah.
Right.
We don't say you have to die because you're of this age or you have this wrong with you. It's like, no, we don't do that.
And I don't know, maybe this is just something that I've been doing this 11 years, and in my 11 years, I never thought we would ever be in a situation where we would even have to think about that.
Yeah.
To even sit here and talk about it, it's just never been from the time we got out of respiratory school. I mean, you feel like, there's enough resources to go around for anybody who needs it, and those decisions would never, ever need to be made. You never would imagine sitting here and talking about this, you know, being a problem or an issue.
Yeah.
I'm curious about what Nikki wrote and saying that a person can be a DNR in patients over a certain age.
She wrote, I was in a code where ICU said we can change code status now to DNR, which is, to everyone listening, do not resuscitate in patient over certain age. I'm not sure, did this actually happen here in the United States, or we know it happened in Italy? If it happened here in the United States, I don't think will be a doctor's decision. Nikki, can you clarify your statement here? Might be a choice that the family made, or the patient prognosis, maybe. What do you guys think?
I think it's illegal here if a doctor said that.
Yeah.
Yeah, I mean,
Yeah.
you have advanced directives. I mean, you can't really get away from those advanced directives unless a power of attorney makes a change, as far as I understand.
Mm-hmm.
Everybody on the code team has a decision when to cease that code. If anybody ever objects, they need to speak up.
If you encounter this, Nikki, this is unethical. It is illegal here in the United States, as far as we, all three of us, know. And I think I'm trying to be up to date with all the legality in our, jobs, but I might be mistaken. But as far as I know, it is still illegal here in the United States. Maybe in time of emergency, the family might make a last minute decision, or if the patient cannot be brought back to life, you have to end the code. You cannot continue a code forever. And we all, unfortunately, were at that spot at some point where we had to call the code off. You're just exhausting all your options. The person is not coming back to life, but you cannot make a decision of ending someone's life if there is still a way of resuscitating them. I think that's what we understood from. Okay, well, Nikki answered you. She said, yes, the doctor said that if a patient is coding, they can make a full code DNR and basically stop the code. You want to answer that, Janet?
I do not agree with that.
And I will report that doctor, Nikki. If
yes, I
were
would
you,
Nikki. Yes.
I will report that doctor, because this is not his decision to make unless it's medically necessity. It's the medical necessity or the best option to do. But you cannot change someone's full code status to a DNR. This is not for doctors or nurses or RTs to do.
That's right.
Mike, have you ever encountered something like that?
No, it's unheard of as far as I understand it. I never heard of it, never seen it happen before.
Okay. Okay. Well, Nikki, um, yeah, she said she doesn't agree. We know you don't agree either with it. It doesn't seem right. And yes, if it does not seem right, that's mean it's not right. So what I will
Mhm.
do, I will report that doctor immediately, and uh, let your superiors take care of this, and I will follow up with it. I'm not just going to report it if that's the case. But to get back to our topic, there is not enough ventilator as we know now. There is not enough RTs, respiratory therapists. We don't need them, like what Janet just said. We are not at that point yet, and hopefully we don't get to that point. But if you are all following the numbers that the Department of Health, the Pennsylvania Department of Health, give out every day and updating us, it is getting there. We are not getting to, hopefully not getting to become another New York or Italy. We're hoping that the curve will be flat sooner than later. But what do you think about premature opening businesses? What I know this is not, it might not be your professional opinion, but your personal, and maybe part of it being an RT, being out there. What do you think this will do to us now?
I mean, I look at it as, did you ever pick a scab before it's done healing?
Thank you
I
for
mean,
putting it this way. People will understand it, I think.
yeah, it's probably not a good idea.
No, not
Um,
at all.
Obviously, there's a we're in an economic crisis, and nobody wants to, every day that goes by where everything is shut down, it makes a deeper hole for us to have to dig out of economically. But I think the question comes down to, it comes down to is the value on preserving life or preserving the economy?
Uh-huh.
And somebody may say the economy is more important at this point, and they may have reasons to justify that, and they're free to say whatever they want to say about it. Um, I think the majority of people are going to probably um, agree that it's probably
Like,
best for people to keep social distancing, to keep quarantining until we can make sure that the curve is
it's
flattened
for
or lowered or whatever, and make sure that we do this properly.
Janet.
I do feel that the it needs to plateau for a month prior to opening any businesses.
So in another word, even if the government said, okay, go ahead, what do we want the general public to know? Uh,
It
you know,
hasn't slowed down currently. I mean, they keep saying it has, but we keep seeing waves. It's like one week it'll be like this, and the next week it's crazy, and it's. I just feel like people need to just try to deal with what they're dealing with at home, stay in. I know it's financially a burden on everybody.
mhm.
Physically, we're going to become exhausted in these hospitals trying to care for these people. And they need to understand that we're not invincible, Eventually we're all going to be, taxed to our breaking point.
And when people go out there and get sick, the healthcare worker is the one going to get hit. I know those people are gonna be miserable, they're gonna be sick, yes, but who is gonna be at the end receiving the large amount, facing those, and maybe unwanted decision to make on prioritizing, or just simply choosing who, and we hope this not going to happen. But if people go premature, like Mike said, picking up scab before it heal. You know, you open up the wound again. You're opening up the wounds again. You're going to start another wave, like Janice said. And so even if they open business, please be cautious. Don't just go out there. Keep the social distancing. If you can afford staying home, do it. If you cannot, go to work, but practice the same thing, the safety. Wash your hands. Do everything that we all talk about. You've seen it on the news, you know, where if you feel like wearing the mask, make sure you get. I know that there are certain masks that are just for healthcare workers, and we have shortages now. So be mindful with that. But Nikki said we need tests first to know real numbers. Not everybody's going to be tested. That's the problem. We don't have actual numbers, right?
Correct.
And the test is very, not just expensive money wise, but I heard it was painful. I hope we don't have to go through this. But, you know, just to avoid having this issue, stay home, be safe. That's all you need to do. Stay home so the healthcare worker can be home for their kids and their family too. Correct, guys?
Yep. I think there's a perspective. I think there's a perspective that some have, but not everybody understands. And that perspective is that it may not just be, let's say, for your younger and middle-aged population, for them to be concerned about their own health, but for the others that they could infect. Say they go out into the community and they do become infected and they're not getting tested, they're not symptomatic, but every door they touch, every elevator button that they push, somebody who will or could be infected may come behind them. So I think that perspective needs to be looked at as well. That I'm not going to shelter in place because it seems like I know 5 people that have it and they're fine. So if I get it, it's not a big deal. Well, if you get it, you could infect 10 other people who may need a ventilator.
Exactly.
So that's something too I think we need to look at, is the perspective of not just us being infected and, you know, suffering. It's how many other people could you infect if you're not even that symptomatic and you could be carrying it and not know it.
Okay. Any last words, Janet, you want to say or share any thoughts or anything that you want people to hear or know about?
I just think people, I lost my volume. Somebody had called on my phone, but I think people just need to know that this is not a joke. This is real. You must wash your hands and constantly be cleaning your doorknobs, and don't touch your pets or your children or anything without washing your hands first. It's very important.
Mike?
And all I would say is, from a healthcare perspective, just understand that there's many different fronts. There's many different areas within healthcare where people are doing different things. In one facility, they may have long-term residents. They're trying to keep it out. They're trying to keep the virus from coming in. There's people that haven't seen their loved ones in several weeks because of quarantines. There's other facilities, there's other places where people are suited up and they're elbows deep in COVID-19 trying to save lives. So there's different people are doing different things on different fronts. So Janet might be exposed to it more than I am from, you know, my seat where I work. But we're all fighting in different ways for the same result. And the healthcare workers we're getting a lot of support, and I'm really excited to see the national response from the community, where people are just reaching out. I get phone calls and text messages from friends and family like, "Hey, I just want to let you know how much we appreciate what you're doing." And that feels really good. That's really awesome.
And it's the simple things that matter. So everyone out there who is watching us right now, I hope you learned something from those two with their knowledge and personal and professional opinion. But more important is to know that respiratory therapists are in the front line. So is the other healthcare worker. Be safe if it's not for you and for your family, just to save those workers' life, first of all. And it won't hurt to say thank you. Simple things that does matter. And I want to thank both of you, Michael, Janet, for everything that you do every day, fighting in the front line and just being out there speaking about this and trying to educate. But moreover, thank you for everything that you're doing during this crisis. And I'm glad that you were both able to join. And hopefully everyone that joined us now late, they will be able to go and watch this from the beginning. If they have any question, reach out to Janet, Michael, or just post your questions here and we will be glad to answer them. Everyone just be safe, practice loving each other, caring about each other, and as always, check up on your family, your neighbors. Make sure that the loved one are taken care of, not just physically, but mentally also. Thank you very much for both of you. And
Thank
be
you,
safe.
Hagir.
Yes, thank you, Hagir. And everybody else, all you nurses, doctors, essential personnel, everybody out there that's out there helping us. Thank you.
Yeah, please be safe.
Thank you.
Signing out.
Signing out.